Welcome to Webinar Wednesday. We are excited for today's presentation featuring Justin Mahan, Clinical Engineering Manager of Parkland Health, Mark Cooper, Clinical Engineer also of Parkland Health, and Heidi Horn, Vice President of Global Enablement for Healthcare at Nuvolo. Justin, Mark, and Heidi will take us through the steps Parkland Health and Hospital System has taken to become the foundation for a healthy Dallas. Webinar Wednesday would like to thank our sponsor, Nuvolo. Nuvolo helps companies better manage enterprise assets using modern mobile, real-time reporting and an industry-leading cloud-based platform. Visit nuvolo.com for more information. A few reminders before we get started. MD Expo Tampa will kick off in 4 days. This 2-day event has been approved for up to 13 CEUs by the ACI. We are thrilled to bring this one-of-a-kind conference back to the HTM industry, and there is still time to register online at mdexposhow.com. If you are unable to join us in Tampa for the MD Expo, make sure not to miss our December HTM Mixer in Nashville, Tennessee on December 9th and 10th. Please visit htmmixer.com for more details on this event. Let's give one lucky attendee the opportunity to win a Webinar Wednesday Webinerd t-shirt by answering the following question. What is the name of the CEO and founder of Nuvolo? You can find the answer on our sponsor's website, and you can answer by using the questions feature on your webinar dashboard. All right, today's webinar is eligible for 1 CE credit from the ACI. You can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinars@mdpublishing.com. As I mentioned earlier, our presenters today are Justin Mahan, Mark Cooper, and Heidi Horn. Heidi, you may begin whenever you are ready.
Hey, thank you. And for those of you who do not know who our CEO is, I know the answer, so I'll take some extra cash my way to give you the answer for that t-shirt. Okay, well, I want to welcome all of you to Optimizing Healthcare Technology Management. I'm really pleased to have the team from Parkland Health here and Hospital Systems to talk about their journey converting to Nuvolo and really how they've optimized the solution to do a lot of amazing things. So I'm going to first, we wanted to introduce ourselves. As mentioned, my name is Heidi Horn. I'm the VP of Product Marketing for Healthcare at Nuvolo, and have been here for about probably 1.5 years. I'm trying to think of doing the math in my head here. And prior to coming to Nuvolo, I actually worked as the Vice President of Healthcare Technology Management for a large health system in the Midwest. We had about 22 hospitals, and I had about 110 HTM technicians reporting up through me. Did that for around 20 years. So I am one of you, and really pleased to be working at Nuvolo now and helping them with their and working with the clients too, such as Parkland Health. So I'm going to turn it over and let Mark and Justin introduce themselves.
Yeah, this is Justin Mahan. I'm the manager of the clinical engineer team for Parkland Health and Hospital System. I've been with Parkland since 2014, previously with another large healthcare system in the Dallas DFW metroplex. And been here for about 6 years now, and I'll let Mark introduce himself.
Yeah, Mark Cooper. I'm a clinical engineer. I work for Justin. I've been with Parkland 4 years, just turned 4 years, and prior to that, I had extensive years of service working in third-party industry for some of the major players
All right, let me go through the agenda real fast, and then I will turn it over to Mark and Justin to explain what they did at Parkland Health. So we are going to talk about the introduction to Parkland Health and Hospital System, and again, go into what not only their organization, but how they have the challenges from their legacy CMMS, what they did to decide what criteria for choosing a new CMS solution would be, the benefits from an HTM modernization. They're going to do a 20-minute solution demonstration. And we're also going to talk a little bit about at the end about what a connected workplace in healthcare looks like and how one goes about doing that. And then we'll end with some questions and answers. So please hold your questions or type your questions into the questions box there, and we will answer all the questions at the end. Okay. Okay, now I'm going to turn it over to you, Justin.
All right, thanks. So if you're not aware, Parkland Health and Hospital System, we are the public hospital for Dallas County. We're the safety net hospital. We are definitely a large hospital. We have a very large population in Dallas. I did check today, and our current bed capacity is around 935. Due to COVID over the last few months, our bed capacity has increased a little bit. So it was previously around 862 once we went live in the new hospital in 2015. But over a few years and pandemic, you grow a little bit. So we do have outpatient clinics and youth and family clinics throughout the DFW metroplex that we support. All in all, we have a little over 33,000 medical devices that we support. And like I said, our system, I guess, has been around since 1894, but that hospital you kind of vaguely see in the background right there, that one was built and we opened it up in 2015. And at that time, we obviously implemented a lot of new technology, a lot of innovative solutions. And we are one of the most connected hospitals in the country. We use a lot of data-driven processes. I think we're a HIMSS level 7 analytics hospital, so we are heavily invested in technology, and it keeps us on our toes. So next slide, please.
Okay, so some of the changes and the challenges from our legacy CMS system. We didn't really have a call tree. We didn't have a centralized place that our users could call to get a call routed to the right place. IT had their system, facilities had theirs, CE had theirs, EVS had theirs, and there wasn't really a connection point. So a lot of times work orders would come into our system that would be for one of the other. I'm sure you guys have all run into that yourself. Facilities and biomed equipment, sometimes there's a blurred line. For instance, here, clinical engineering biomed does beds, but facilities does stretchers. We do surgical lights, but they do exam lights, and it's hard for a user to know which one to go with. Now, as we all know, in the last several years, the lines blurred between CE and IT. So we'll get a call for a medical scanner, for instance, or we'll get a work order put in the system for medical scanner. Well, it's really an IT device that's hooked to their workstations. So we didn't have a method of saying, oh, okay, this is an IT call, reroute it. Basically, we had to reinvent the wheel by calling IT and putting in a ticket for that vendor and then canceling it in our system. And a huge thing that we wanted, especially with a hospital the size of New Parkland, is a mobile application. So our technician would be on the 16th floor and get a call for something on the 13th floor. If he came all the way back down to the basement, then got the call and had to go all the way back up, wasted some time and wasted some effort and energy getting him back up there. A plus was the fact that you could do your PMs, you could close PMs, close work orders, and do all of that on the device as checklists and maintenance guides that are accessible. So totally mobile, totally able to move into the future. And again, the another nice thing about it was when you did send a call to a technician and said, hey, you need to go do thus and such, it's nice that the system allowed it to automatically acknowledge that work order so that you, as the person who dispatched them, could see that, oh, he got it and it's all good. Now we can move forward. Next slide, please. So some of the advice that I could give when you, and some of the things that we looked at when we were selecting a new CMMS package, was the plan for the future, not just for now. We knew what we needed now was pretty much what we had, but it was all of the things that we wanted to do in the future that made selecting a platform like this good. We wanted something that had, again, a single platform that allowed all of these other disciplines, all of the other support groups in the hospital, IT, EVS, linen, all of these people to be able to be in one database so that you could move data back and forth, you could view data, you could communicate between the different departments through the software. The fact that it was extremely customizable was helpful. A lot of times our department sits and thinks of what's a new thing that we can do, what's something else that we can be as a value to the hospital. A perfect example of that, when COVID broke out and we were preparing for things, we had to create a report 3 times a day to send to our command center, telling them what COVID related devices were broken, which ones had, were down for work orders, what did they have available. We couldn't give them a usage number because we didn't store that, but they could get that part easily. What we could do is tell them, hey, you have 55 ventilators, 6 of them are down for parts or whatever. And we were able to real quickly add a button, a checkbox that said COVID interest to an asset record. And within an hour, we were able to dump that report automatically every 3 times a day. And we could do automated reports. We didn't even have to interact with it. And the fact that the Nuvolo could do that for us in less than an hour was amazing. Another huge feature that we wanted was the contract management module. And Nuvolo's is pretty robust. It allows you to predict when a device is going to be due for, the contract is going to need to be due for renewal. Allows us to get a return on investment, to see, hey, is it worth continuing to have this contract? Are we spending more money, or would we have spent more money going time and materials, or would we have spent less money? And Justin's going to get into that here in a little bit. One of our favorite features, I'm going to go to in just a minute, is the reporting and graphical dashboards. It allows you, Nuvolo allows you, for example, and any system needs to allow you to be able to extrapolate and pull out and extract all the data that you've got in the system and make it into something that's usable when you need it. And coupling with that is performance analytics, which allows you to go even greater in depth. To me, performance analytics is just like regular dashboard reporting on steroids, because it allows you to use formulas and plugins and things like that to create and forecast data, to be able to forecast when a device, how often it's going to break, how many hours this year has that device been down, things like that. And finally, we wanted it to include the ability to forecast in years to come, or how many, 10 years, 5 years, 10 years down the road, when we were going to have to replace the device, so that we could forecast the budget by pulling all this together into a dashboard and look at it and kind of levelize how much money we're going to spend on replacement devices and not miss anything. And next slide.
Yeah, and to kind of expand on that, we really wanted like an enterprise solution, right? So when that me? I don't know what that was. The situation we were in, we had a couple, different types of systems. Obviously, clinical engineering. We had our CMMS that we used to support medical equipment. But at the time, like I said, like we were also in this process of onboarding, or I guess we're building a new hospital, right? And so because of that, a new team was built on the supply chain side to inventory basically everything for the hospital, not just medical equipment, but everything for the hospital. So there was this asset management team that tracked all the stuff we did, plus, a lot of different stuff. So there was a lot of disparity in what they were tracking compared to what we were tracking, and how they onboarded things and retired things and how we did it. And so we wanted to go to kind of a single solution for everybody going forward. And one of the things that we did is that instead of, when we went live with Nuvolo, instead of the clinical engineering team, whichever team it was within our department, instead of them creating new asset records, technically when the device, the new shipment comes in through the dock, asset management, they inspect it, they make sure the order matches up against the PO, everything's there, they receive it, and then they also inventory it. So they tag it, it goes into the Nuvolo database, and it's categorized as a clinical device, right? So those are the things that our department supports. So when they do that, we automated it to create an initial inspection work order. So we would never be at risk of not having initial inspection work orders for new devices. And once the equipment gets to our department, it allows for the appropriate technician to take it to, onboard it, put it together, get all the device specific information, like MAC address, IP, whatever it is, operating system, all the things that they need to do to all the additional information that they need to gather and document within the database that asset management didn't do. And it's, like I said, it's all kind of their form. All they got to do is look up the asset number and enter the remaining information, and they have their work order already right there for them, and they can just put their time on it and attach any appropriate documentation or anything like that. So it's kind of the onboarding process. We wanted to automate it and make it more reliable and consistent. That also leads into kind of the retirement process too. Like I said, we had different databases that we managed and asset management managed. And so if we retired something, or if we said, we pull this out of clinical use, maybe it makes it out of our database, but it doesn't make it out of theirs. So again, we have inconsistent data. So we wanted to have a way where we consistently retire things. It goes through the proper, gets proper signatures, gets proper review, goes through the proper process to get through accounting to get depreciated, to make sure it's getting written off the books or whatever it is. And everybody sees that it's automated, it's auditable, we can trace it, it's all in a consistent space. So that's what we did too. There's actually once we implemented that process, once we automated it in Nuvolo, we actually discovered the piece with accounting that they actually do review everything that is retired to make sure, it is fully depreciated and it can be written off and things like that. So we're modifying that process to include them in that workflow. So hopefully we can get that running sooner than later and get away from any manual paper processes that we've historically had. But also within that process too, there's controls in place, right? So we've set it up to where somebody in clinical engineering, we can't just retire something arbitrarily, right? We can inactivate it and make it to where maybe it doesn't generate PMs or something like that, but we can't truly retire it until it goes through all these processes, because we don't have the proper permissions to change status to that status level. So it would actually have to go through somebody with asset management to fully retire something. So we kind of, we tried to build in controls and things to where, it I guess limits the risk or any potential issues that could come up if people aren't following the proper process. Also, as Mark mentioned, contracts, right? So, man, when I came on board, I think we were managing contracts just on an Excel document. Worked well enough, right? But it's totally separated from the database. Any work order history in the database. The only people that can access the Excel document are ones that knew it existed in the first place, right? And it wasn't on any SharePoint or anything anywhere. So if a technician or one of our imaging engineers or somebody like that wanted to look at the terms and conditions or what's covered under the service contract, they don't have access to any of it. They have to go find somebody to dig it all up for them. So we wanted a way to put all this in the database, and that's what we did. And that's one of the things we'll review once we show our demonstration. So I won't dive too far into that one, but it has been a big improvement for us. And then asset lifecycle management, right? So clinical engineering at this hospital, we manage the replacement of all existing medical equipment. So we do the lifecycle management of it. Any net new requests, obviously those are kind of submitted by the end user department, the departments that have the justification on why they need to, implement some net new technology or service, and we're involved with that, but we manage the replacement schedules. And so if you're managing, something on the scale of 33,000 medical devices, valued at roughly $350 million, you can't just you might have one year where you spend $1 million, another year where you got 20 million, another year where you got 40 million. It's all over the map, right? And especially when you do build a new hospital, you might get a whole lot of net new equipment, which if you're replacing it kind of on a standard depreciation life cycle or some other formula, a lot of things are going to come up due for replacement in the same year. So we needed to spread that out and normalize it. And again, in our demonstration, we'll dive a little bit more into that, and hopefully it'll make sense. So next slide. So work order management. Again, as Mark said, when you have multiple different teams, multiple different divisions in the hospital, it can get a little challenging sometimes, right? Like you can't really expect the nurse maybe to know the difference of, this computer does this because it's a medical device, and the computer right next to it, well, that's an IT computer. Or as you mentioned, this is a I don't know, surgical table, right? Well, the exam bed next to the surgical table, two different teams support both those, that system. CE supports the surgical table. Somebody else, like facilities, might support the exam table. So there's opportunities for confusion. We wanted to kind of limit that. We knew it's going to happen. We know it's going to happen. It's going to continue to happen, but we need to figure out better ways to automate the routing, and also just automate the routing within our team. So we have a biomedical support team, an imaging support team, electromechanical support team, and an OR support team. So even just within our own department, it can get kind of confusing, and they all, have different ways that they're assigned to areas or equipment or whatever it is. So for our work order management, we wanted to automate as much as possible. So we built groups within Nuvolo. So if an asset number is used to create a work order, whether it's through our self-service portal or through a call center, if an asset is used, it's great because it's going to automatically route to the appropriate team, and it's going to notify them however we have it set up through pager, email, or whatever it is. And then it can escalate from there if they don't respond in appropriate times. But if they don't have an asset number, which happens quite a bit, you can't force somebody to have an asset number, even though it'd be great if we could. There's ways to say, okay, well, is it an imaging device or is it a biomedical device? We hope that's a little bit easier to distinguish between, but if somebody can ask them if it's a diagnostic imaging device, hopefully most people would recognize that. So that can also be a trigger to at least route it to the appropriate support team as well. So we built additional questions and things like that in our self-service portal, and different script questions that our call centers can ask too, to help route it to the appropriate teams when an asset number is not available. And then obviously we all share the same work orders, so work orders kind of, anybody can see everything. It's just really the routing of the initial work order, make sure the appropriate teams are notified. Team performance is a big one. So, in the past, it was very manual. It'd be manual, like if you wanted to just, balance workload amongst your team or do performance goal evaluations, whatever it is, it was all, let's run a manual report, do an export, or try to kind of I don't know, run reports on a scheduled basis and update a document or something like that as you go throughout the year, and then have individual meetings with your team on a regular basis to just talk about their individual performance, not necessarily like a team meeting or anything like that. It wasn't a very transparent way to do things. It required a lot of manual interaction by our support managers and the technicians and the imaging engineers. They just didn't, like I said, they didn't have a lot of transparency. They're like, you get to a performance goal at the end of the year and you didn't hit it. They're like, well, why? My numbers, I thought they were good. Where was I not hitting like these goals that you wanted me to hit? So through performance analytics and some different dashboards and reports that Mark has built, everybody has standardized dashboards that they see on a real-time daily basis. It's right there in front of them. They can see what they're being measured against, how they compare to their team members. So really, I mean, there should be no question at the end of the year or day or whatever it is, if there's a question about did you get all your PMs done on time or whatever it is, like it's all right there in front of them. And it also allows managers just to kind of look for outliers, manage teams against each other, just look for areas for improvement and things like that, so it doesn't get missed. And cybersecurity, obviously, that's a very big one right now. We do have Mitigate, a tool that's in place, so we have an active project to integrate that into Nuvolo. So that's a good new thing coming up for us. It's very exciting. So not just the cybersecurity management of it, but the data integrity of it, of making sure we have proper IPs, proper MAC addresses, proper OS levels, patch revisions, all different things like that in our database, and that it's updated real time, and it helps us to make more educated decisions on replacement planning or risk management or whatever it is. So next slide, please. And yeah.
Okay, so everybody should be able to see my dashboard screen. Going to go through a few of the dashboards real quick. We use the dashboards almost exclusively to drive our view of the data, because like I said before, the greatest thing about the dashboards is it allows you to access data, to extract data, and to view things that if you just looked at a list of stuff, or if you dump this out to a report, you may miss, but the computer never misses it. And we have a leadership dashboard that we start with. The main screen shows all of the pain points, all of the things that we want to see on a regular basis, almost instantaneously. Dashboards are dynamic in the sense that this refreshes I think I've got it set for every 5 minutes. It'll go through and refresh, and these numbers will change based on whether somebody opened a work order, closed a work order, changed the status of it, all of this. And this we use a lot. Our director, Travis, he attends these morning meetings. They're called huddles with all of the VPs and stuff in the hospital. And a VP will say, yeah, our CT went down last night. Travis can hit up on the dashboard and see that says a huddle event. He can access that right now. He goes, yeah, it went down. It was a power supply, and he replaced it, and it's back up. And so basically you have the answers to your questions instantaneously. And we change these frequently depending on what's a big important piece in our mind at the time. This is the 30,000 foot view, if you will. This is what our leadership sees. We have various different tabs. We'll go into some of these in a minute. I don't want to go through every one of them. Our managers then, they have their dashboard, which is going to exclusively show just the things that is important to their team or to the teams he manages. So he can see what, like Justin said, he can gauge the performance. In this case, this manager has the imaging team and the electromechanical team. So he can look and see how are work orders looking. Is something been out there, setting out there for a long period of time? Are there PMs that are overdue that need to be taken care of? He can look at it. He doesn't have to go ask questions. He doesn't have to pull up reports or anything else. It's right in his face. And again, the beautiful thing about it is, I didn't point out, but any of these are interactive to the point where if he goes, oh, I wonder what this is, he can click on that and it's going to pull up the actual work orders that is involved with that. So you've got the answer you want, even as you want it. So in addition to the leadership and then the managers, each employee has one that just has their data on it. I was going to show you one. I can't show you one because it's tied to the login. And if I showed you mine, it's just got a bunch. I don't do PMs. I don't do CMs. So my screen wouldn't give you any data, but just understand that it would go down to the employees level. We also quarterly, we meet with our hospital. We divide up, it's large enough that we divide up into divisions. And I think we have 15 divisions that report to 15 different vice presidents. So we meet with each division quarterly to discuss PMs, safety posts, any issues that we have, damage and abuse issues. And one of the things we do hit that we're going to talk about in a minute is equipment that's coming up due for replacement for whatever reason. So it kind of keeps us all on the same page. They're not in a panic wondering if we're on top of their data. We show them their contract information, where they're at, where we're going, what our plans are. And we do that under, it almost looks the same as the other one, but this is specific to, in this case, surgical services. So we could go and look at their preventive maintenance information. We could look at their assets that they have. We could look at any recalls, their contracts, and their equipment equipment replacement plan. Our goal, and this is not a limit of Nuvolo at all. It's a limit to our own IT department not wanting to expose this, I guess is the right word for it. But our goal is to have this available to the managers of these different divisions and the VPs of these different divisions anytime they wanted to. They could just log on and see where we're at, where we're looking at it, all the way down to what work orders do you guys have for our equipment that aren't completed and why. And right now, IT hasn't figured out how they want to roll that out in an Active Directory status to where it makes everybody in the hospital a user.
Yeah, I think this fiscal year they were supposed to budget for a select few, so maybe just the leaders of each division or department to have read-only license. So that's something
right.
we have to implement.
Yeah.
I don't know, when you have obviously 10,000 plus employees, they don't want to have license for everybody, and some people won't use it, right? So we try to narrow it down to a select few as possible. So hopefully within the next year, we'll have this as an option for read-only access to the clinical leaders.
Now we're talking about performance analytics, and performance analytics is a dashboard on steroids. So a dashboard will give you a report, and you can make a report of number of work orders open, number of work orders closed. Performance analytics can give you things like how long was that work order open? How long was it in the work in progress state before it moved to the next state? I used it initially as we went with it for our EOC committee and our EOC reports, so that I could all of the metrics that we report out, I don't have to go run several different reports or do any computation. It tells me every day what it looks like. The number here shows you today. This shows you, we report two months back, our status 2 months ago when we go to EOC. So I just set this parameter. This shows that in September, 2 months ago, we opened 443 non-life support. We closed 443, and that was 100%. And I first of all, I did it in all the pretty pictures because, again, I'm hoping that they can come up and see that at any point. But I also broke it down to something that looks more like a spreadsheet, which is something more people are used to seeing. So now I can go back and look at the last 12 months and show what we did each month. The current score, this one here, this is this month. But I did the non-life support, the high risk, the life support, and we still break it out, although they all have to be 100%. We still like to show the difference. Everything, equipment damage and abuse, use errors. I can give you percentages. On the damage, I can not only give you the percentage, but I can give you the cost. All that's there and available through that. One cool thing that we just explored, and we're just in the process of exploring through performance analytics, is we want to look at if there's an opportunity to improve how we document and what we document. So the data here is real. I didn't fake anything. We first of all started this as we created it. We wanted to see how much, and this is time that they've actually written down on work orders. This has nothing to do with their clock time. This is the information that they've put on these work orders, broken down by the week that they put it in. And what it's taught us is everybody's kind of good. You do have some really weird situations that come up, and we don't feel like it's a punitive thing at this point. It's an education thing. We can go in here and go, hey, why did you only do this? And we may look at it and say, oh, he was on PTO for 4 days. It's a piece that we're trying to work into it, but our first step is let's educate. There's no way if you saw 75 hours in a week, that's really not realistic. But it does give us a chance to look at that. And then to take that to a different step, we wanted to look at in our clinical documentation, for instance, let's go to October. We had 3,855 hours of documentation. 1,500 hours was for corrective maintenance, and that's about 40%. 1,200 was for PMs, and that was 31%. Then PTO for our 35 employees was about 125 hours for 3%. And then everything else, initial inspections, projects, and everything else was 900. So it allows us to look at it. And I always learn, again, coming from a independent service organization, our thought in our head was always, well, you should have 3/4 of your time devoted to preventive maintenance and 1/4 of your time devoted to corrective maintenance and other things. And it's not that way, at least for us. And I don't know that we don't know at this point whether that's a good thing or a bad thing, whether we need to maybe do more PMs to make that number. Is it really a flip? Is it really equal? Because it does to us, it looks like it's almost, for the most case, it's almost 50-50 split. And so performance analytics allows you to trend that, graph that, look at that and go, well, what do we want to do? What do we want to do with this? Our goal at Parkland and in the clinical engineering department particularly isn't just to spit out PM, CM, safety post information at these committees. We want to be able to give them dynamic information that's progressive and to show what can we do as an organization to improve the product. We think we got a quality product. When we come up with a new metric to look at, we first noticed that, wow, I didn't know that it was going to look like that. And then we figure out how we can improve that. So we use the dashboards, we use the performance analytics to really look at our data in a way that you don't look at it in any other method. And it allows us to find things that, I'll go to this one real quick for a minute. This is, I call it data integrity. These are all the things that are either on a work order or they're on a medical or on asset record. This is data that we want to have to be 100% accurate. And this shows me areas that, oh, look, and now this is not a big concern. These are just brand new pieces of equipment that came in this month and last month. So I know that I need to add cost centers to 124 of these 134 records. I need to add division to 70 of them. We have some work orders that are on devices that are inactive, and this is one of those cases of where you have 2 unable to locate PMs. So this time you inactivate it. Well, they forgot to go back in and close off those other 2 work orders. This lets me pull that out and find it. So it's information like that that's very helpful to us. And that's why we use the dashboards. Now, Justin is going to go into the predictive maintenance, the capital asset replacement plan.
Yeah. So one of the big things this team does is it's life cycle management. It's capital management of the assets. So we again, you know, any finance director, anybody like that, they probably want to or finance CFO, whoever it is, they want to know what they're going to spend year to year, or at least have an idea what the expectation is, right? So like historically at Parkland, it was just, you know, whoever yelled the loudest kind of got what they wanted. But and there was a lot of neglect for existing medical equipment. There was real no structure put around it other than, you know, what vendor sent us an end of support letter. And hopefully whenever they sent that to us, it was at some point in time where we could actually budget for it, and we weren't like at the start of our new budget year or something like that. So we said, okay, how can we get ahead of this? How can we be a little more predictive? And let's just provide a plan to finance to say, hey, listen, if we put some sort of logic around this, this is what we're looking at year to year over the long term. And again, I'll reference that we did move into a hospital in 2015, so it wasn't like it did have a lot of new equipment in it. So it wasn't like we've just kind of normalized everything over a long period of time. So we kind of had to start from scratch and re-normalize everything. So this graph that this bar chart that Mark's highlighted on right now on the top left, when we first started, it was basically, I mean, it was like a triangle, right? It just, everything was like in 2024, I think, 9 years basically after, or I guess, yeah, 9 years after we opened. So we had to move some things later, move some things earlier, try to put some logic around it. And then kind of how we do that is based off asset type. So anytime anything's onboarded by the asset type, we add, it automatically calculates the AHA guideline plus 2 years. So we don't specifically just go off the AHA guideline. We add 2 years to that to try to kind of spread it out a little bit more. And then we use other criteria to move it, you know, forward or later in schedule based off multiple different types of considerations. So as you can see, I mean, we got a little more normalized. We flatlined it pretty much as, I don't know, flatline's probably a bad word, but we normalized it as much as we could. As you can see, we still have some stuff in 2020. Those are active 2020 projects we still have going on right now. So as we complete everything out of our 2020 budgeted list, eventually that'll go away. And then, you know, we just kind of continue down the road. It's just perpetual program. Just real quick on the right, that's our minor equipment budget. So that obviously doesn't, that's for us, capital is 5,000 or above. So these are individual assets that are below 5,000 a piece, you know, excluding any large fleet replacements, anything like that. So these things are just really replaced on a run rate. So we track it here just kind of as a reference to see where we're at, but there's really no proactive action or anything we're taking on that. So, you know, if we don't replace something in a specific year that it was scheduled for replacement, we just kind of roll it over to the next year. But we can always kind of dive in deeper to see how long have we been running with some of this stuff. Does it make sense to maybe proactively do some of it? You know, where are we getting? And we do things like that, like our AEDs, like that's coming out of this bucket, stuff like that. But mostly that's just a run rate. So again, here's the bar chart so we can kind of just see high level year to year. It's good for kind of executive presentations. Then we go down and we have this table here, and it's basically by asset type. And it shows by asset type what we anticipate spending each fiscal year, or at least budgeting for, right? We use more list price for budget price, not really what we paid for it. So these are budget prices, and once we actually go to budget for it, you know, we'll dive in a little deeper, get some quotes, start evaluating what other considerations like, you know, integration licenses or middleware or anything like that we'd have to consider to add into our capital request. But this is kind of our starting point. And again, it's all interactive, so you can dive into to any of these. And so it's a good overview, but it also allows for any anomalies, right? So if you have, I don't know, 50 something anesthesia machines, that's a big expense. And maybe you don't want them all due in 1 year. Maybe you want to spread them out, or maybe it's something where you do want to do them all in 1 year. You need to normalize it or standardize it. You need to look for a fleet replacement. Well, here you can see, based off at least device type, if you need something all in 1 year, well, it's obvious if something migrates out of that year for whatever reason. For example, the one Mark's on right now. So those are like our iStats, our point of care analyzers. Well, one's in the wrong year. So for whatever reason, the acceptance date of that one differed, or somehow it got moved out of the wrong year. So all we need to do is go in there and edit that and change it. And on the asset level, we have this little replacement plan tab that has different sets of criteria in it. So you can see in the top left where it says 7 years. So AHA guidelines for that device says 7 years. So it takes the acceptance date, so the date we put it into service, inventory, did all that stuff, got it ready for patient care, add 7 years to it, and then in the background we add 2 years to that. So it's just a little formula. So it puts it in, it technically would have put it in 2024. But since, again, we want the ability to override that and standardize things or normalize things as needed that makes sense for our organization, we have this little ERY, which is a evaluated replacement year override checkbox, which allows us to edit that evaluated replacement year. This one technically should be 2021, and that would put it in with the fleet. And we also have some boxes that have key criteria for replacement and different types of rationale. Our goal ultimately, so this was kind of our baseline, right? Let's just put some kind of default questions there, stuff like that. Because getting into a fiscal year for replacement based off age is one thing, but you really want to start diving deeper into, okay, well, if we do replace it, are we replacing it with the same exact thing? Is there new technology out there? Is our new technology going to add new features, functionality to improve patient care? What other factors can we consider? Is our machine, whatever it is it breaking down a lot? What's the support status? What's the sales status? Ultimately, we want to get to a point where all that stuff is kind of factored together and it gives you almost like a risk score. And so that'll be like our capital prioritization score for the year. And as we budget for these things, then we would have that prioritization score that would, move it up or down in our list per year. And that would also help with the justification to our executive leaders on why we need to do something. If you just go to them and say, hey, this thing's 9 years old, that doesn't really do much for them, so they want to know, okay, well, how many do we have in the system? How many do we have in that department? Are there backups? What happens if we don't have this machine? Can we get support for it? Can we get, if we have to buy a new one to expand our fleet, can we get the same exact one? What's the standardization? So that's kind of our next step after this, is adding all those things together so we can have more meaningful data and documentation to present to our executive leaders as we go forward.
Okay. Hey, Justin, I want to do a quick time check. We got 10 more minutes, and I want to leave some time at the end for questions. Do you want to show contracts real fast, and then we'll move in, allow about 5 minutes for questions?
Yeah, I'll run through it real quick. Sorry, we rambled. So this is contracts. This is really a list of contracts that are coming due for renewal within the next 6 months. We'd like to give our contracts department 6 months to at least to renegotiate some of these, and also for us to evaluate if we still need to move forward with it. Again, we have them assigned to different clinical engineers to balance the workload out. We have the contract costs. We have our annual expected cost for that contract to help with our operational budget. We have our term links. We have the type, which is either T&M contract, full service contract, whatever it is. It's all customizable. We have it by division. So as Mark mentioned earlier, we do these divisional meetings so we can show and filter to their contracts that apply to them, just in case they have questions about them. Just dive into that Fax Canto one real quick, Mark, if you can, that second one. Second one from the top, yeah. Again, so we have vendor, we have contract costs, we have our service PO associated with that contract. We have, as you can see at the top, we have our attachment. So we have the PO that's for that contract that we issued to the vendor. We have the signed contract, which is all the agreed upon terms and conditions. So that's all available here for reference. This isn't what our contracts department uses, but we take that documentation and put it in here for our own reference. Scroll down a little bit, Mark, down to the bottom. And so what you do too is you assign your assets and the coverage types to your contract. And that allows you to, on an ongoing basis, track any costs, any work orders, any costs, anything like that associated with these devices under your contract term length. And ultimately at the end, you can say, okay, well, here's our charges against our contract. Our contract was $60 whatever thousand. We, I don't know what our total was. Go up a little bit.
Yep.
As you see on the right over here, it says, okay, well, we would have spent $14,000 if these weren't on contract based off the service reports we had. So we really only got a 20% ROI. In a perfect world, that's accurate. One of the challenges we realized is that a lot of vendors don't provide their what would have been costs on their service reports, right? So they just say covered under contract, no billable rate or charges or whatever. So that's kind of our next step here is, okay, well, let's try to, when we're negotiating this contract, require them to tell us, what would have been the time and materials rate if we wouldn't have been off contract. That would help us justify it a little bit more. Hopefully we can get some buy-in for that. So a lot more, but if y'all have questions, I'm sure y'all can contact us later on, but we'll open it up for questions now.
One thing I wanted to close with real quick, you'll notice it looks like some of these had an end date that's in the past. It's because it's actually being negotiated and it probably has completed negotiation with contracts. The contract's still valid. The new contract's in place. We just haven't got the paperwork yet to update our system.
Yeah, sometimes it overlaps for whatever reason. So it's not an automatic process that changes state off end date or anything like that. So, but we do have it on our, that dashboard there. So everybody can look at it and see it and, not forget where, what is going on with this contract. Is it in place? What happened? So, yeah, it's a good point, Mark.
I'm going to pass this back to Heidi now.
Great, thank you. Okay, should be able to see my screen now. Thank you, everyone. So I'm not going to spend much time on this slide because I do want to allow time for questions and answers. Just, and I think this slide is just essentially wrapping up kind of the whole presentation and what we do at Nuvolo. So as you can see, the connected workplace in healthcare is something that, we do very, very well. And I know that Mark and Justin touched on this. So, whether you're in HTM, clinical engineering, facilities, field service management organization, or you're looking at your project capital planning, even things that, again, OT cybersecurity. So those are your medical device cybersecurity management and things like real estate, space and move. All of those can be done from one application through Nuvolo and allows the organization to and the healthcare system to collaborate, coordinate with each other. I think they touched base. I think another interesting webinar would really be to get the facilities team from Parkland on this conversation. And I know that one of their future things that they're working on is being able to transfer work orders between the organizations as well as between IT and HTM and facilities, so that again, as you'll have tickets come in that somebody said, well, this is my patient monitor is not connected to my, to Epic or Cerner, and then you realize it's an IT issue. So you want to transfer that ticket so that you have full understanding, full history of what happened, and you can track it. And those are all things that can be done through Nuvolo. And so what I would encourage everybody to do there, if you go to our website, nuvolo.com, it'll actually walk you through some of the use case scenarios of that. So I'm going to turn it over back to Technation and let us know what the questions are so we can answer those. But again, we've really appreciated all of this.
Thank you all so much for a great presentation. We do have a few questions that have come in, and as a reminder to our audience, if you do have a question, please use the question feature on your webinar dashboard to send in your questions. Anything that we don't get to on the call today will be answered directly by our panelists after the webinar. Our first question today is for the Parkland team. Have you had any joint commission audits while using Nuvolo? And if so, how did having the Nuvolo software help with that audit?
I don't know, Mark, you want to answer, but I mean, yeah, we've how long we've been live with this? 3 years. I know we've had
almost 4, yeah, 3.
4. We've had CMS reviews, Joint Commission reviews, CAP reviews. I mean,
state audits for imaging.
Yeah, state audit. I mean, anything you can think of, I guess. There haven't been any challenges, honestly. I mean, it's helped us. We also did migrate our old database into this one as well, so we had all our historical work orders in it. So I mean, we never really had any issues as far as running any work order history or historical reports or anything like that. We've, if anything, it's improved it. I mean, we've set up the ability to send reports to different departments, and in case they were asked questions during a tracer or whatever it is, that they would have history of their own devices. But I mean, no real concerns. I don't know if you can think of anything, Mark. But
no, I think I agree with you. It's been easier because it is all together, and because it's cloud based. No matter where you're at, you can log on to any computer or any networked device and pull the data up to show it, even in the middle of the hall.
mm-hmm.
Great. All right. Well, we'll make time for one more question. And like I said, if any questions that you have, please still feel free to send them. We will send them on, and they will be answered offline after the webinar. Our next question is, who manages the CMMS in the organization, and how much time does it take or save versus the old system?
Oh, darn, we ran out of time. No, that's a hard one for us. So we in our old system, we pretty much managed it for the most part in our department. That's one of the functions of our team is database management. Once we went to this solution, it is piggybacking off the ServiceNow backbone. So the ServiceNow application support team kind of took some ownership of it. We're in the process of negotiating some of that back in a very I guess, I don't know, appropriate way, I guess you should say, because there's a lot of things that we do. We don't just use it as a tool that sits there and once it's deployed, it is what it is. We need to be able to modify it, improve it, kind of all the things we discussed, make decisions on the fly, change things. Sometimes we don't really know what we're asking for, so we need to play around with it, try to figure out how we can improve it or get the results that we want. So the system itself has a lot of different abilities on permissions, privileges, stuff like that. Just unfortunately, since it is an enterprise solution and it's part of the ServiceNow backbone, how we deployed it here, you definitely want to have those conversations up front on roles and responsibilities and support and stuff like that, because we have some sister hospitals, hospitals in the area that we work with that also have Nuvolo. They're set up a little bit different. They have a little more control than we do. But again, that was maybe just some assumptions we made in the beginning that we didn't define as well as we should have.
All right, thank you. We have run out of time, but thank you so much, Justin, Mark, and Heidi, for your time today and for a great presentation. I would like to encourage everyone to visit today's sponsor to learn more about the products they provide to our industry. Please visit nuvolo.com. A quick reminder to our audience that you can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you will be able to download your certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinars@mdpublishing.com. We will be back next week with another webinar. Please visit webinarwednesday.live for more details and for complimentary registration. Thank you all and have a great day.